Okay, we're gonna go ahead and get started. Thank you everybody for coming. We're heavy on the left, that's okay. As always, we record these meetings for our YouTube channel, so I hope that that's all right with everyone. If you are not comfortable being videoed, the videoing is happening right up here, so really, most of you will be out of screen anyway. So welcome, I am Melissa Moore. I do substance abuse prevention work at the health department. In front of you, hopefully, you will have our agenda for today. I like to put these together just for people's references, as well as on the back of your agenda, the announcements that are scrolling, which I'll go through. Hopefully you also have one of our evaluations. This is helpful for our funding, as well as to help us with improvements, continued improvements for the work that we do. And then 2 events, which I will go over. And if you need CEUs, it's kind of a nice thing they do track them for you. You can request them at any time. We do offer 1 free CEU. Those forms are over by the pens as well. So if you didn't get one of these, you can fill one out and leave it at your place. Evaluation, same thing. You can leave at your place, or you can put them on the end of the table and we'll collect them at the end. So thank you for coming. A couple things to point out that are coming up. I'm going to get out of the scrolling thing so they don't scroll past as I'm trying to talk. I do talk fast, but we're not going to go through like that. So coming up next, is it next week already? It is. Next week is going to be the final session for our Overcoming Addiction series. This is in partnership with AHEC, which is the Area Health Education Center. This session is going to be held on Thursday the 15th as well as Friday the 16th. It's going to be a repeated session. In Wausau, we're actually very fortunate to have the keynote, Jeff M. Vonderen from the TV show Intervention, is going to hang around after that session during the daytime hours to have kind of a little jam session. So if people want to sit one-on-one, have conversations with him, it's a great opportunity to kind of get to know, who he is, what he does, and ask questions. He's also going to be around for an evening session. The last time we had an evening session with him at DC Everest last November, we had about 200 people attend, which was great. Is there anybody in the room that was able to attend those sessions, that session last year? So, I mean, I anticipate we may see some repeat people at this because I think that he is really good. I think he talks with so much kind of wisdom and knowledge that I think you probably could go on to more additional information. So the evening session is free. The daytime session is $20 unless you're a recovery coach. They actually have no charge for that, students or peer specialists. So it's an opportunity for people to attend. And they do offer registration still. It's still open on that. This Thursday, we're going to have an open house for our overdose fatality review team. Last year, August, we actually held our first overdose fatality meeting. What it is a collection of multiple agencies working together, looking at deaths of individuals in our community and touch points for prevention. So looking at things like, is there enough access to medication drop boxes? Or is there enough education going out to tavern owners, for example, on signs of overdose? So we've been able to identify some things that we've been able to move forward in the community or are moving forward. So it's an opportunity for you not only hear about our overdose trends, which I'll cover a couple coming up as we talk and move through the day, but also just the ability to kind of meet who's on the team and just hear a little bit more about its purpose. Already mentioned YouTube. One thing I'm going to back up to this is, with this being the 3rd session, our first 2 sessions, the keynotes were recorded. So if you were not able to attend those sessions, the first session had Dr. David Mays. He's an addiction expert from Madison. He was very, very good. So you can see his viewing, or you can view his part of his keynote, as well as one on, I think, motivational interviewing. And then our second session had Judge Everett Mitchell, who's a Dane County Circuit Court judge. He talks about his experiences with adverse childhood experiences, what he grew up with and how he incorporated that into his courtroom. And we also had Scott Webb talk about trauma-informed care and kind of moving that forward in a systems approach. So those recordings are available. Definitely take a moment, check them out. Definitely worth your time. A couple other free events that are coming up. Partnership for Youth is holding a professional development day on the 14th. I do believe that registration is still open for this. Again, it's going to be at DC Everest Middle School in their theater. I hear that she's a fantastic speaker, so if you are available and you're interested in attending, make sure that you register for that. There's a really big push in the community to engage youth in talking about a lot of the critical issues impacting them. There's actually a kind of a night of expression, as they're calling it, on the 15th, excuse me, from 6 to 8, and that's at the new Whitewater Music Hall, which is right across from the J.C. Penney ramp, if you're familiar, across from the kayak course. So it is something that is available, is open, and I think that it's kind of one of the first events that they're doing for this, so it's a neat initiative. Another educational session coming up is the third Hope Consortium Conference, and this is really looking at things like treatment, recovery, how do you support it. There is a cost for registration. There's information online, but it is something that, again, is closer as far as continuing education goes. We will be holding our 6th school networking event. Many of you already received this, but it's just an opportunity for schools to come together with youth serving organizations, local treatment, school resource officers, and so on, to really just kind of talk about what they're seeing in their schools, talk about what are the things that we can do together, and looking at how we can continue to collect our youth risk behavior survey data, which helps us out a lot. And just one other thing, if you don't follow the Wausau Police Department on Facebook, you're the only one. No, I'm just kidding. They also have a Twitter feed, but they've been really heavily promoting their picnic. I see they're doing it in conjunction with the fire department this year, so this is a free event for people to come, go hang out, meet the officers, see some of their equipment that they have, and so on. So just for your reference. And again, you have all of these on the back of your agenda, and this is going to be posted, I think it already is, on the AOD Partnership calendar, so you can download these and view them if it's kind of tiny. I do apologize for that. So with that, just looking at the agenda, we are going to be doing our 8th annual Faces of Recovery Luncheon, and I haven't set the date yet, so please stay tuned to your AOD Partnership weekly updates. If you don't currently get the updates, there is a sign-in going around. Make sure that I can read your email, and I'll make sure I add you. We send those out once a week, and they include meetings, trainings, volunteer opportunities, a variety of things for folks to do. So that all those things come out through that. Is there any other partner updates before we move on into the educational portion of the day? Hearing none. If you do ever have any events that are coming up for organizations that you work with that you would like me to send out through the weekly update, go ahead and send them over to me. I'd be happy to do that. We've also sent out things like job postings. If it's something that's appropriate to send out through the update, we do that as well. So it is available. It is a kind of a nice thing that we've been able to do. So before we bring up our featured speaker, I'm just going to kind of set the table, tee it up, and talk about why this is titled "People Don't Start with Heroin." As we got talking, and I met with Heather, and I'm going to have Heather come up here in a little bit, from Robert's Therapy, we were talking about, like, what are some things that, at this time of year, what do people need to know? And we kind of got to talking about, with that being a physical therapy clinic, sports injuries, for example. When I talk to people that have heroin addiction or history of heroin addiction, they don't start there. They start with prescription medications. They start with prescription opiates. And a lot of the times that first taste could come from something like a sports injury. So we got to talk about what are really the important things that people need to know, what are the things that people need to ask, how do you advocate for yourself through healthcare, not only for yourself as adults, but then also for your children as well. So it is something that very much find important, because when we talk about prescription drug abuse, typically we see it in 3 different categories. We see the prescription painkillers absolutely is at the top. When we had to sort our medications for our medication drop box program, we had about 1/4 to 1/3 of all medications collected were the controlled substances that fit into one of these 3 categories that are in front of you. So your narcotic painkillers, your central nervous system depressants, and then your stimulants. So you have your muscle relaxers in your second category, you have your sleep medications in your second category, in your stimulant category that could be ADHD medications, for example. So this is kind of why we need to talk about this, because I think a lot of the times we focus through media. I love them, don't get me wrong, media, we talk a lot about the bad stuff. We talk a lot about heroin, we talk a lot about methamphetamines. And people don't necessarily start there. They start with some sort of related prescription drug. They're readily available. And this slide actually, that came from the National Survey of Drug Use and Health, while the data may be a little bit old, you can see that it's referencing to, you could see that when somebody starts with or is using heroin, they trace it back. It's not necessarily starting with, you know, some of these other substances. Prescription painkillers is really a direct link. They just don't start there. And this was actually a recent presentation that was done by Dr. Eleanor Katz for SAMHSA. You know, you could see on the first image, 3 out of 4 people who use heroin in the past year misused prescription drugs first. They started there. We saw a huge push with heroin in our community in 2010. It was the same year that they reformulated OxyContin, very popular painkiller, the Brett Favre drug. It was everywhere, and it was given for everything. They reformulated it to make it from a pill that could be crushed to essentially a Skittle. So if you ever stepped on a Skittle, or a now and later, or not now and later, there's another one, a Spree, something like that, that can't be crushed, that's kind of what really led us into that heroin epidemic. So when people couldn't get pills anymore, they went to heroin. Plus, heroin's cheaper. At one point, you could get a good dose of heroin for $10. Now it's about 40. For, if you can imagine, trying to think, the width of a standard staple, that little bit, like the length and the width, very small amounts. The second side, or the second image you can see, is that, you know, it's not as simple as I'm going to go from pills to heroin. People will abuse both at the same time, and that's really what that illustrates, is that if you're abusing any sort of opiate, you're going to take another opiate or a synthetic opiate to try to maintain a level where you can function. Because at some point, you don't enjoy that high anymore. You can't enjoy that high anymore. You're using to feel normal. So the rates are kind of astronomical, and again, this is just another image that came through SAMHSA and looked at how, you know, we talk about opiates a lot, and people sometimes automatically for a long time are going right to heroin, and it's really not the case. We need to talk about prescription drugs as well. But I think if I was going to say to you, I'm not going to have you raise your hands or indicate in any way, but if I was going to say, what does a prescription drug abuser look like? You have an image. You may not have thought about it, but you probably have an image. If I said, what does a heroin user look like? You have a different image. They're the same image. They're the same population. And that's really what, you know, I'm here to talk about, you know, just kind of, again, this is something for all ages. The doorway is open, and sometimes this is where people walk through. So when we talk about, and I already mentioned as far as the overdose fatality review team, to date in Marathon County, we've had 5 overdoses with 3 additional that are suspected. 80% of those that are already confirmed, so that would be 4 out of 5. 80% of those were either fentanyl or a polysubstance use that included fentanyl. Fentanyl is big in our community. Now, do I mean it's the fentanyl patches that people are being prescribed for pain or for cancer treatments, for example? Nah, not necessarily. You just don't see those anymore. This is not only legitimate fentanyl that people are prescribed, but also illicit fentanyl. Fentanyl that's coming in from China, for example, and being sold on the street in powder form, liquid form, pill form, you name it, you can get it. So fentanyl is definitely huge. And when you look at fentanyl being about 50 to 100 times stronger than heroin, that's why it's so fatal. That's why there's such a high fatality rate with it. Last year, just to give you an idea, we had 7 overdoses in 2018. So our numbers were actually down. That's all drug overdoses. So our levels have changed. Is it the availability of naloxone and Narcan? Because there was a big push to do a lot of trainings in 2016 and 2017. We saw some lowering. Is it the shift from using heroin and other opiates to more methamphetamines? Absolutely as well. So there's a lot of things that contribute to this, but I think the thing to bring away is that, you know, fentanyl is definitely what's contributing to our deaths here. So why do we need to talk about this? Why is prescription drug abuse even a problem? Why do we need to keep it to the forefront? Think 5 years ago when you watched the evening news. What were the ads in between? Even less than that. Over the last number of years, you may notice that of the 5 ads, for example, you're seeing 3 prescription drug ads. I have to laugh because my husband and I were watching the news the other day, and I think it was a Humira ad came on. And all of a sudden it was for some other condition. We're both like, well, wasn't that for rheumatoid arthritis and now it's for like, I think I've heard it for like 2 or 3 other things. So they're putting a lot of money into this, and I think a lot of the times we do get down on the alcohol alcohol industry, absolutely. 5 years ago, we were seeing more beer ads during the high prime time than you are now. But when you look at how much is being spent, and honestly, when I look at how much is being put into prevention of medication abuse, it's just an abomination. Not to get up on the soapbox here, but it is definitely something that the stewardship of resources, both for disposal as well as for that prevention education, is pretty lackadaisical. So like I said, when we look at prescription drug abuse, this perception that they're safer versus illicit drugs is something that we ask every year, or every other year, excuse me, you have a copy of the highlights from our last medication assessment. If you don't have one, there's extras up here. If you want to take extras, please do so. So this is our 2017 version. One of the things we say is, how risky is it to take more medications than you're supposed to? How risky is it to take medications that are not yours? Compared to illicit drugs, which one's safer? So we ask this question because when it's prescribed by a doctor, when it's FDA approved, all these things, we think there's this kind of overwhelming feeling that they're somewhat safer. But when you're taking medications not as prescribed, taking medications not for you, taking them for a purpose that they're not intended, you are abusing medications. That's that definition of it. The availability, like I said, they're everywhere. This is something that's pushed out through multiple media sources, and that acceptability of it. There was an opportunity a couple years ago during the Super Bowl. On a national level, they put out a number of awareness initiatives, awareness campaigns, and this was probably pretty early on in the opiate epidemic, right when it was first coined, and they were doing some preventative type of messaging on it. There's a drug company that instead of taking that opportunity and buying their placement to help contribute to that message, they took that opportunity to advertise their new drug, which was going to help with opiate constipation. So Super Bowl ad, here's your medication for opiate constipation. I saw that and I'm like, I said some things I probably shouldn't have said, but I just kind of sat there dumbfounded because this whole idea is, here's the pill that you want to take for this. Oh, you have side effects, here's a pill for that. You have side effects, oh, here's another pill for this. And unfortunately, this is kind of a cycle we're in. So I'm excited to hear about some of the alternatives, specifically, when we talk about opiates for pain, what is it that we could do? Because, to get out of that cycle, I think it's going to be something that we need to do as a nation. So, as I said, opiates are derived from the opium plant, so they can be synthetic, they can be generated in a lab, but they are all based on that particular plant. You see some of the popular brands here. This actually came from Military Health. They have a lot of great resources there. I have another resource slide coming up. Some of those protection things, one of the things that's not included in your packet, but there's cards over here, is if you're not using medications, we have 8 permanent drop boxes in Marathon County. If you live in a surrounding county, you can go to the Department of Justice site and find where your drop box is. I believe every county around us has a drop box in their county. At one of the local police departments or sheriff's department. You can call their local departments as well and they could tell you. We are going to be adding, by the end of the year, every single one of our local police departments in Marathon County. That will be 11 will have drop boxes. We're also going to be adding a community sharps box for people that are looking to dispose of their sharps in a safe way as well. So there's a lot of things that are happening here. We're very fortunate in our community. Not every community is as fortunate as we are. One other thing that I encourage people to do is recognize those signs of overdose, because you could be in a public place, you could be in a parking lot, you could be driving down the street and somebody crashes their car. Recognizing the signs of overdose is really important. What you can do, obviously the first thing, check the airway, call 911. Same things that you would do if you come across anybody that's not breathing or struggling to breathe. There is some bookmarks over here that Winnebago County put together, so if you didn't pick one of those up, it talks about the signs of overdose. There's some here as well. We're going to be developing our own local materials as part of our overdose fatality review team as well. So a lot of good things that are available. So I'm going to stop my part with a video. So the CDC actually is one of the resources that's on the list. They've put together a number of different videos. This is one of the things, like, as an organization you can help share. I like it because it does give some of that true story. It doesn't necessarily use some of the scare tactics that I've seen some awareness campaigns do, because we know scare tactics, especially when it comes to youth, don't necessarily work. So I'm just going to show this quick. It's shorter. I didn't check the volume, so I hope we don't all get blasted.
My son was 20 years old when he was prescribed opioids.
I think I was 16 years old. I must have gotten a 30-day script. I took them all in 3 days.
A car ran a stop sign and completely T-boned us.
Nothing mattered more than getting my fix.
I was given a prescription opioid pain medication, and within only a few months, I was completely addicted.
My brother RJ had me believe that he knew exactly what he was taking.
My son Steve did not want to die, but his prescription opioids killed him.
It's likely that everybody knows somebody who is struggling with this very problem.
I was stealing from people, buying substances on the street, and I look back at that time with a lot of shame. You know, that's not who I am.
I want people to know that these drugs are addictive, and one pill can equal death.
There was nobody to tell me that these have a really high potential for addiction.
My son overdosed at the age of 22 years old.
We lost RJ at 32 to prescription opioid overdose.
You never expect that you're going to lose a child. It's all out of order.
My dad took one pill too many that ultimately killed him.
It just takes one.
So with that, I'm going to bring up, if Karen and Heather want to, I don't know if both of you coming up. Just Karen? Just Karen, perfect. I will put her, I just kind of, she has her full bio on our website. You can come on up. Kind of. I would probably have her introduce herself in the abridged version when she comes up. But you can see that she's very active. We're really excited to have her here representing Robert's Therapy. And one thing I meant to do is print these off for you. But again, this is going to be posted onto the website. I did put together some suggested resources that have a number of different things available as far as workplace, youth initiatives, Department of Health, and so on, as well as the Dose to Reality. Generation RX is another community awareness initiative that you can access. So this will all be posted onto the website. A lot of these are also in the front here on the helpful web links. And just another reminder about that overdose fatality meeting. So I'm going to pull up their presentation. She's running away.
Yes.
Like, you don't have to run away. It's not so scary. So just a reminder again, make sure that you eventually do the sign-in. If you're missing any of the materials, let me know. We should have them. So you can click or you can click, whatever you want to do. I'm going to leave them both up here.
Okay.
I'm going to get out of the way.
All right. Thank you.
Welcome, Karen.
Thank you. So thank you all for having me here. I feel like I'm a little offset here. But again, my name is Karen Monarski. So I'm a physical therapist currently with Roberts & Associates Physical Therapy. I am a 1989 graduate of Marquette University program in physical therapy. I'm actually a transplant from southeastern Wisconsin up to Wausau here, but that's been 2 decades in the making, so I'm here to stay for a while. I was the co-founder and vice president of Priority Physical Therapy, a private practice physical therapy clinic from 2007 to 2019. In April of 2019, Priority Physical Therapy, after years of collaboration with Roberts & Associates Physical Therapy, we were acquired by them. Roberts & Associates Physical Therapy operates 6 physical therapy clinics and 1 fitness center across the state. And our closest location, of course, is here in Wausau, where I practice out of, is just down the street at the corner of Merrill Avenue in Randolph. So I'm excited to be working with the therapists at Roberts & Associates who are participating in various opioid task forces at the local and state level. And so this is kind of my first step into all of this. So again, I appreciate your attention. I also welcome any questions. Since this is relatively new for me, and this group in particular is new to me, if I'm not answering the questions that you came with, please let me know, or if you want clarification of anything that I'm talking about, please feel free to let me know about that either during the presentation or afterward. Okay, so talking a little bit more about, kind of adding on to what Melissa was talking about, 2019 healthcare challenges. The opioid epidemic is creating significant healthcare challenges across the country. 2016 saw 214 million opioid prescriptions written for pain, a rate of 66.5 prescriptions for every 100 people. I saw that and I was like, whoa, that's 2/3. 1 in 5 people receive prescription opioids long-term for non-cancer pain in primary care settings. More than 11 million people abused opioids in 2016. Every day, 1,000 people are treated in emergency rooms for misusing prescription opioids. And 40% of all US opioid deaths in 2016 involved a prescription opioid. The CDC estimates that the total economic burden of prescription opioid abuse at $78.5 billion a year. 2017, 916 Wisconsinites died from opioid overdoses. From 2014 to 2017, 319 Wisconsinites died in motor vehicle. Every day, 2,500 American youth abuse prescription pain medication for the first time. How do we get here? A little lesson, and where did this all come from? It's really an unintended consequence of wanting to help people. Healthcare providers are the ones that prescribe the opioids. We want to place the blame, but they're not the villains. They subscribe to a Hippocratic oath: first, do no harm. So the goal is to treat the pain and take that away from the patients. But there were consequences that we didn't expect. Empathy and compassion drive people to want to serve and to help improve their fellow humans' condition. History of Wisconsin's crisis. In 1999, the first wave begins when opioid prescriptions increase. In 2010, the second wave hits when deaths from heroin overdoses begin to rise. 2014, the third wave hits when deaths involving synthetic opioids like fentanyl begin to rise. Fentanyl was linked to illegal manufacturing as mixed with cheaper drugs like heroin. What drove the uptick of opioid prescriptions? So back in 2000, this is a statement about JCO, which is the Joint Commission on Accreditation for Hospital Organizations. So it's an accrediting body that lays out standards of care. And this statement states, excuses for inadequate pain control appear to have run their course and will no longer be accepted because poor pain control is unethical, clinically unsound, and economically wasteful. So there was really this push to treat pain, to make sure that patients aren't in pain. And healthcare providers wanting to meet these standards and do the best they can for their patients are seeing that are learning that narcotics are a safe and effective tool for managing pain. So that was the prevailing notion underlying the Spring Leadership Summit on Pain Management, sponsored by Joint Commission on Accreditation of Healthcare Organizations and the American Pain Society. What is JCO? I already spoke to that. And here's another statement from 2001, that the goal was to manage patients' pain by abolishing it. And there's some pretty strong language in here. For over a decade, experts had called for a better assessment and more aggressive treatment, including the use of opioids. Many doctors were afraid to prescribe opioids despite a widely cited article suggesting that addiction was rare when opioids were used for short-term pain. Education guidelines and advocacy had not changed practice, and leaders called for stronger methods to address the problem. The standards were based on the available evidence and strong consensus opinions of experts in the field. Again, back to 2000, view on pain. Well, actually to 1990, Dr. Mitchell Max, the president of American Pain Society, wrote an editorial in the Annals of Internal Medication decrying the lack of improvement in pain assessment and treatment over the previous 20 years. Education, advocacy, and guidelines from the U.S. Agency for Healthcare Policy and Research, the American Pain Society, and the World Health Organization had not worked. This failure was attributed to patients not telling their doctors and nurses about their pain, nursing not being able to adjust doses, and physician reluctance to use opioids. Pain was often invisible. Unlike vital signs, such as heart rate, respiration, etc., pain isn't displayed in a prominent place on the chart or at the bedside or nursing station. Now, this was back in 1990, and I was practicing back in 1990, and I remember clearly when these standards started to come out that we were always having to address pain. And you know, the standard was to always to start asking the patient what's the number on the pain scale. You know, how bad is your pain? So that was actually relatively new back in the 90s. So physicians were rarely held accountable for inadequate pain control, and they had not implemented systems to address the problem. Pain relief has been nobody's job. So it was really seen as something that was completely unaddressed, an unaddressed aspect of care. And then, so the focus changed to addressing that vital sign. And that, of course, is one of the contributing factors to where we're at today. Dr. Max emphasized the conventional wisdom of the day: therapeutic use of opioid analgesics rarely result in addiction, although this was based on only a single publication that lacked detail about how the study was done. He lauded the Wisconsin Controlled Substance Board's cancer pain initiative that led to a 10-fold increase in morphine prescribing over a 12-year period. So is it a surprise where we're at today? The one study that was quoted to drive and change the conventional wisdom came out of Wisconsin. So where do we go from here? Current best practice to manage pain. Taking a biopsychosocial approach which utilizes a combination of physical therapy, psychological therapy, such as cognitive behavioral therapy, and social support groups avoiding isolation. You know, things that will cause a person in pain to kind of dwell on their pain, which actually increases their pain. So in a study from American Board of Physical Medicine, 2017, patients with early access to physical therapy were 35% less likely to receive opioids. And so the title of this talk was focusing on youth, but really it's not only youth. This is youth and adults too. So Wisconsin-specific legislative efforts to address effective pain management. 2017 Wisconsin Act 59. The 2017-19 biennial budget requires the Department of Health Services to study best practices for physical medicine and the impact of the use of physical medicine has on the use and frequency of use of prescription and over-the-counter drugs by individuals who receive benefits under the Medical Assistance Program. Act 59 also requires that DHS develop a proposal for a physical medicine pilot program using chiropractic, physical, and occupational therapy services to minimize the prescription of addictive drugs for these individuals. The bill defines physical medicine as rehabilitation techniques that aim to enhance and restore functional ability and quality of life to persons with physical impairments, injuries, or disabilities. So just to touch a little bit more on that, on the physical medicine, including physical therapy, which actually isn't in here, but I think is important to speak about, is that physical therapists well, first of all, we assess people from a neuromusculoskeletal standpoint, meaning we're looking at bony alignment, we're looking at muscular structure, muscular strength, flexibility. We're looking at movement systems and how are the body parts working together? Are they working together in a way that's efficient, in a way that doesn't contribute to strain and joint pain and pain conditions overall? And then we identify those impairments and then utilize physical strategies to address them. Physical meaning non-medication. We don't use medication in physical therapy. We'll use physical modalities such as manual therapy, where we're applying our hands to the body to assist with stretching or mobilizing a joint or helping to reduce sensitivity to pain in an area that may be painful to the touch, or you feel the tightness in the muscles. That physical touch can help reduce that tightness. Again, we're looking at strength imbalances. Is there strength in a muscle? Is there more strength on one side of the joint than the other side of the joint that's creating an unbalanced forces at a joint? And so if we address the parts that are weak and balance that out with the parts that are strong, that's going to help reduce and balance out the joint forces to help improve pain. Pain and function as well. So we look at things like what we call basic functional mobility, your ability to get up out of bed in the morning, get up from a chair, walk through your home, walk through the community. All of those things are the kinds of things that we're focusing on. Wisconsin-specific legislative efforts to address effective pain management. Direct access to see a physical therapist, meaning a referral to see a physical therapist is not required, has been around in some form or another since 1989. So again, that was the year that I graduated, that I was a baby therapist, right? So it's been interesting to see the evolution of that and to have looked back in my career. So back in 1989, the practice was still focused on physicians were the ones who ordered physical therapy. And since then, there's been an evolution of patients being able to directly access physical therapy. So that definitely reduces the amount of time that somebody starts to feel pain and is able to see a physical therapist and start to implement strategies that are going to help address what's causing their pain. The physical therapist, if you were to see somebody in that situation, the physical therapist then is the one to assess your condition to determine that it's appropriate for physical therapy. This isn't on your slide. So it's, you may not know for sure, I don't know if this is appropriate or not for physical therapy. Sometimes we actually get referrals from physicians who aren't sure if this is appropriate for physical therapy. But it is the job of the physical therapist to assess that condition to determine if it is something that's within the realm of physical therapy. Is it a neuromusculoskeletal condition that can be addressed with physical modalities? And actually, to address that, the profession now is the newcomers to the profession are the entry-level degree for physical therapy is a doctorate in physical therapy to address that situation that of direct access to the physical therapist, that the physical therapist is really a primary care provider in that aspect, and that they are determining that, yes, this is the treatment that's appropriate. And if not, that they refer on to another discipline, okay? You know, there are certain conditions that are simply not appropriate for physical therapy. The primary one would be if somebody came with evidence of a fracture, a bony fracture. That's something that I can't treat, you know. That's going to require imaging, that's going to require services of a physician to be able to assess and treat that. Medicare now also allows for a patient to see physical therapists without a referral, but not all commercial insurances do. So if you go to a physical therapist seeking a condition, that's something that falls within the law, but if you want that reimbursed by a third-party provider, your insurance company, that may or may not be allowed. At Roberts Physical Therapy, we actually do a verification of your benefits to find out if, you know, if that's something that you want, if you want to seek services and pay for them through the insurance. We ensure that that is something that we don't need an order from your primary care provider. And then help you seek that out if you would need that. Okay. So, prior to 1989, ideally, although this still happens, that the initial meeting, if somebody starts to feel pain, and of course this is utilizing back pain because that is so common, you might start feeling pain, but you don't necessarily get to your provider for another month. Because, oh, you know, lots of things to delay that, right? Oh, I can live with it, it'll go away, you know, it costs too much, all of that. So all of this creates a delay in the initial meeting with the doctor, and maybe they're going to their primary care provider, who isn't quite sure, you know, maybe there's something that's going on outside of their realm, so they send them to a specialist. The specialist sends them for imaging. Then they have to wait to see their doctor again to get the results of that imaging. And then that provider creates this plan of care that includes physical therapy. This is based on the imaging. This is appropriate for physical therapy care. Whereas with direct access, you have immediate access to see the physical therapist, who initiates an evidence-based conservative program, and it starts movement right away, begins addressing those mechanical situations that are contributing to the pain, and can greatly shorten not only the duration of care, but the cost of care as well. So the whole time the patient is going through this assessment cycle, what are they doing? They have back pain. You know, oh, their friend's uncle had back pain and they had surgery and that didn't help, and they had another surgery and they ended up in a wheelchair, and now they can't walk. They're in a wheelchair and they can't work. They're disabled. That, you know, that creates a lot of fear of that pain, and it creates avoidance of movement. But our bodies want to move. Joints want to move. They're made to move, right? Immobilizing a healthy joint can actually contribute to pain and stiffness, okay? So that lack of movement creates not only pain just from not moving, not doing what it wants to do, but it can also create a loss of strength and will also create a loss of strength and flexibility. That can contribute to movement dysfunction. That creates more strain, more joint dysfunction, et cetera, that will contribute to more pain, okay? Unnecessary imaging that, you know, unnecessary imaging, meaning x-rays, MRIs, may lead to the patient kind of catastrophizing their pain, that, you know, they, when we hear the results of our x-rays, we may hear that we've got arthritis, we've got degenerative disc disease in the back, we've got all of these things that are going on that actually are normal, that are normal parts of aging and not necessarily indicative of pain. Okay, if you take images of the general population, you're going to find that just as many people without pain have positive findings on their x-rays as people who do have pain. It can be helpful down the road for identifying other conditions, but often I hear from patients who have come to me either through direct access or from their provider. Oftentimes it's from their provider. They didn't even take an x-ray, and I tell them, well, I don't necessarily need an x-ray. There are things that I can see that will contribute to your pain that aren't on an x-ray. And these are the things that I can help you do to help address that. So oftentimes by the time they get to physical therapy, because there's been so much time, they've heard so many things from their provider, their condition has become chronic. They're weak, they're stiff, they have that fear avoidance of movement. Every time they move, they hurt. And that's going to increase their length and cost of care. So how can we change this? Patients may have to be their own advocates for seeking physical therapy services. Again, either through direct access or asking your physician provider, is this a condition that's appropriate for physical therapy? Is there any reason why I can't be seen by a physical therapist? Is there any reason why I can't be seen by a physical therapist? Oftentimes I hear in somebody that has maybe avoided physical therapy early on is that, oh, I just thought it would go away. You know, and sometimes they're told by their provider that, oh, it'll just go away. But then there's oftentimes something that's underlying that condition, why it started in the first place, that doesn't get addressed. Maybe that initial pain goes away, but there's still a movement dysfunction underneath that might make them more susceptible to further injury, and an injury that's a little more significant and something that requires a little more attention. So even early intervention from a physical therapist, even if it's something that is potentially going to go away pretty quickly, still is appropriate, because you can address those underlying issues and maybe create a scenario now where you're preventing more injury down the road. Okay, that's often addressed too in youth sports, in particular with preseason physicals. My kids are undergoing those right now. I've got teenagers in high school sports, and I do a little bit of my own assessment too. So that will certainly help to identify some of the underlying causes. And there are coaches are certainly. I just recently had a kid who had come in with an injury, whose dad was really involved in. You know, it turns out he was one of the coaches, and it was great to see his interest in his child's physical therapy, because he was learning things that he was going to start to apply to the kids that he's coaching. So that was a great collaborative relationship to establish as far as that was concerned. So injury prevention clinics, where you're identifying those musculoskeletal issues, where you might have specific strength deficits or flexibility issues, and you address those through a general exercise program to improve the mechanics and improve the safety of the child on the field. Okay, so also as far as just helping to guide your physician provider to physical therapy, inform your provider that you're interested in something other than medication to address the pain. A lot of times, physician providers tell me that they feel compelled to give a pill because that's what people want. It's kind of a quick fix, right? Physical therapy, on the other hand, takes a little bit of effort, doesn't it? You know, but I think we can see how there are certainly benefits to the physical therapy over the pill. Okay. So treatment approaches that a physical therapist might take, I've already touched on a few of those. But that graded exercise and movement activities I think is really important. You know, oftentimes people come to physical therapy thinking that this is going to hurt, right? And I really want to stress that physical therapy doesn't have to hurt, okay? Might be painful, might not be comfortable. You know, when you get up in the morning and you're a little stiff, you've been sitting a little too long in the car and you get up, it's uncomfortable, it's stiff, but it feels good to move, you know? That's that good hurt kind of thing, and that's the kind of thing that we're looking for. Whereas if I have somebody who's coming in and is really fearful of movement, and I tell them, we're gonna push through this, no pain, no gain, what are they gonna do? They're gonna become even more stressed about this situation. That's gonna enhance their pain level. That's not gonna help their situation. So physical therapists can really help with a graded exercise program and movement activities that will help reduce that fear avoidance of movement and will help reduce that pain, reduce that sensitivity overall. I had mentioned manual therapy. Oh, sorry, back to the aquatic therapy. Aquatic therapy is actually a great option too if fear of movement is high, because that sensation from the water is relaxing. The buoyancy can help take weight off of sore joints. So that can really be a great option for somebody who's got, whose system is really sensitized to that movement. Again, I mentioned the manual therapy, the hands-on treatment approaches to decrease hypersensitivity of the nervous system. Joint and soft tissue mobilization, I'd mentioned. Trigger point dry needling is actually a relatively new treatment approach where we're using basically an acupuncture needle as an extension of our hands when we're doing manual therapy. So if we're finding, you know, trigger points in the muscles, the knots in the muscles that can be sore, introducing a small monofilament needle into those areas of restriction can actually kind of help reset that muscle and restore some of the normal mechanics of the muscle. I actually have a couple of like case studies, I guess you could call them. You know, as far as the, I guess going back to the graded exercise and movement activities, oftentimes I see, and again going back to that fear of the fear of physical therapy, and that attitude that there's no pain, no gain. Again, oftentimes I have patients. Patients come to me for rehabilitation after a total knee replacement, or maybe you know, and they for the kids they've had an ACL reconstruction or a shoulder surgery, and they're in pain from the surgery. They may have been immobilized to help, particularly if it's a rotator cuff repair or an ACL repair. They may be immobilized. That restricts the joint movement. That restriction of joint movement really increases the pain that they're having. It increases that fear avoidance of the pain that they're having. They come into physical therapy and they've been told, you know, by their provider, they've been told by people who've gone through this, make sure you take your pain medication before you go to physical therapy because it's going to hurt. So they walk in there and you know, they might be afraid of this. Oftentimes, what I do is simply start with, particularly if it's somebody who's really fearful and they have this real shallow breathing pattern and you can just kind of tell they're all wound up, I'll just start with relaxation exercises, just a breathing exercise. And that can actually help calm their central their nervous system down, can reduce some of that sympathetic nervous excitation, which is that fight or flight mechanism that really increases the awareness of their pain and increases their desire to avoid the movement. So just getting them to do some deep breathing can kind of help tap into that parasympathetic nervous system, that relaxation mode, can help their muscle guarding go down, so that when I do go to mobilize their joint, when I do go to help them bend their knee, for example, after their total knee replacement or their ACL reconstruction, there's much less guarding, and they're able to accept more movement. We get more movement with less pain. So, hindsight is 2020. Based on the historical context, it's not a surprise that prescription use of opioids exponentially increased. Following CDC guidelines and best practice, early access to a physical therapist, use of cognitive behavioral therapy to address the psychosocial aspects of pain management. Okay. Any questions?
So do you do CBT?
I do not, because that's more along the realms of psychotherapists, right? So it's kind of out, but I'm familiar with it, and I've actually had some great collaboration with therapists who do that. And I do help, so oftentimes what it is the patient is being seen by the psychotherapy and coming back with strategies that they've learned that we're then starting to incorporate in with like the breathing patterns and things like that. Okay, so it's actually a great to have that interdisciplinary approach. Yeah, it's actually a great partnership so that where techniques are being reinforced in both realms. So that's where I've had some really great success with patients who have chronic pain and they've been on opioid medication for a long time and they're really motivated to get off of it. Cognitively, they're able to buy into it all too, So.
Thank you.
Mm-hmm.
Karen?
Yeah.
Can you speak to the fact that people can refuse medications if they go in with the injury and get prescribed opiates, for example?
Oh, certainly, yeah. Really for long-term pain management, we're finding that really opioids isn't the best strategy. Sometimes it is needed for short-term, post-surgically acute injury. But there are other alternatives as well, too, and that's certainly something to speak with your provider about. Use of anti-inflammatories or acetaminophen to help manage your pain medication may be appropriate. You may not need the step 2, the opioids, particularly if it's adjunctive with something like physical therapy, early movement strategies, other physical modalities to help manage pain like heat and ice and even positioning, things like that. It's definitely within the realm of the patient's, what they can do for themselves, what they're, you can refuse treatment, yeah. So again, asking your provider about other alternatives, I think is important. It's certainly appropriate.
Are there any other questions? Okay, well with that, thank you. Give her a hand.
Thank you.
So just a reminder of all the different events and stuff that are coming up. Hope to see you there. I'm sure we'll kind of be packing up here. If you have any questions you want to come up and talk or ask individually.
And you get the gift of time today. I will put the resources back up in case anybody would like to see them, but enjoy the rest of your day, I guess. Have a good one.